Well, good morning or good afternoon, everyone. This is Joy Burkhardt with 2020 Mom and the National Coalition for Maternal Mental Health. We're getting started just a few minutes late. Thank you so much for your patience. We're thrilled about this new webinar series called Think, Ideas to Generate Change. This is the very first webinar in this Think series, and we'll tell you a little bit about how it came to be and what's up next in the webinar series in just a moment. Again, I wanted to introduce myself, Joy Burkhardt. I, again, am the founder and executive director of 2020 Mom and also the National Coalition for Maternal Mental Health. We're pleased to have several other guest speakers with us today. Before I introduce them, I want to quickly tell you about how this series and this particular webinar came to be. We wanted to share that the National Coalition hosts annually now lobby days in Washington, D.C. in May. We have a great team of folks from the National Coalition that help put that event together. And this year at the National Coalition Lobby Day at a networking reception, both Dan Martin, who you can see here up on the screen, and myself had an opportunity to present briefly some of the high-level recommendations regarding the California and Maryland recommendations out of their task force reports or Blue Ribbon Commissions that ran to address maternal mental health this year. And we heard back from folks that they're eager to hear more. And so this is, again, an attempt to go into those recommendations in a deeper manner and specifically to focus on the education recommendations. So today our scope is going to be focused on education, provider education, and most specifically we're focusing on MD education, so medical doctor education, and even more specifically the role of psychiatrists, the role of reproductive psychiatrists, and the role of OBGYNs. What will be out of scope for today's presentation is the role of mid-level providers, and of course we know that mid-levels are critical in many ways to detecting and treating maternal mental health disorders. We also won't be talking about pediatric education or pediatrician education today, and again also recognize that that's critical. We hope to address those topics on a future webinar in this series. Well, now I'd like to go ahead and introduce our guest speakers today, and I'm going to start with Dan Martin, who you can see up on the screen. Dan is the Senior Director of Public Policy for the Mental Health Association of Maryland. It's a nonprofit organization that's concerned with all aspects of mental health and mental illness. He has the opportunity to coordinate and manage all of the advocacy campaigns for the nonprofit and public policy initiatives. He coordinates efforts at the Maryland Behavioral Health Coalition and also the Maryland Mental Health Criminal Justice Partnership, which, Dan, we're very interested in and want to talk to you about that on a future webinar as well. He was primary staffer that led the Maryland Task Force to study maternal mental health this year. And before joining the nonprofit, he served as legislative liaison for the Maryland Office of the Public Defender and also as the legislative director for a particular delegate, Bobby Zirkin. He received his degree in law from the University of Baltimore School of Law. So Dan, we're thrilled to have you. Next, I'd like to introduce Stuart Lustig, and you can see Stuart just catty-corner to Dan on the screen. So Dr. Lustig is a board-certified child and adolescent psychiatrist. He also serves as the medical director for child and adolescent care at Cigna Behavioral Health. He served as an associate clinical professor at the Department of Psychiatry at the University of California at San Francisco, and has also served in the role of director of child and adolescent psychiatry for the residency training program for quite a number of years at the university. He's received his doctorate in medicine from Rush Medical College and also completed his psychiatric training at Stanford and Harvard hospitals. Impressive, Dr. Lustig. He also has a master's in public health, which we love, from the University of Illinois School of Public Health. And I think we're going to stop at that. There's more great work that Dr. Lustig has done. We're thrilled that you're with us as well, Dr. Lustig.
Thank you.
Next, I want to introduce Tracy Flanagan. Tracy is an obstetrician and gynecologist at Kaiser in Northern California. She serves as the Director of Women's Health for Kaiser Permanente, again in Northern California, and is the lead for maternity excellence. She received her BA in psychology, which we love, at Barnard College, and also her MD at Case Western Reserve University, and completed her residency at UCSF, just like a connection to the University of San Francisco, like Dr. Lustig. Her past professional experience includes serving as the National Health Services Corps, serving on the National Health Services Corps, and she's, of course, an OBGYN and private practice and faculty practice. She also has experience doing a number of other things, including serving on the California Maternal Mental Health Task Force here. She has 12 years of leadership at Kaiser Permanente and has developed lots of improvement projects, most notably her project leading depression identification and treatment in the perinatal population. We're thrilled to have you, Stacey, as well.
Thanks, Joy.
Next, I'd like to introduce Dr. Payne, and Dr. Payne received her BS in biology and also her MD from the Washington University Medical School in St. Louis. She completed her residency at Johns Hopkins and served as chief resident during her last year there. She's also completed a fellowship in mood disorders through the Mood and Anxiety Disorder Program at the National Institute for Mental Health. Very impressive, and also joined the Johns Hopkins faculty in 2003 and was promoted to an associate professor in 2011. She is the director of Women's Mood Disorder, the Moods Disorder Center, and in addition to providing that service, is interested in improving clinical care for women with mood disorders. She conducts various research, as does Tracy Flanagan, which I didn't mention, and specifically Dr. Payne's research focuses on genetic, biological, and environmental factors involved in postpartum depression specifically. Dr. Payne, we're thrilled to have you as well.
Thank you.
And then next, I am going to introduce Dr. Howard. And Margaret Howard is a PhD and clinical psychologist and professor of psychiatry, and human behavior and medicine at the Warren Alpert Medical School at Brown University. She is the division director of women's behavioral health and established the nation's first mother-baby perinatal psychiatric partial hospital program at Women and Infants Hospital, WIH, in Providence, Rhode Island, where she's located. She has published and taught and lectured nationally and internationally on the topic of perinatal psychiatric disorders, and her interests in research and clinical practice include mother-infant attachment and dyad, and of course, novel integrated treatment approaches for this population. She's also involved in the Perinatal Mental Health Society, otherwise known as the Marce Society of North America, and will be talking to us about the Marce Society's recommendations on education today. So you can tell we have quite a fantastic lineup of presenters. This is the first webinar that we are doing that is going to really focus on the style as a presentation, or panel presentation style, rather. So you're not going to see any PowerPoints up on the screen today. Rather, we're just imagine that all of us are up at a table and that you're viewing all of us up on a table at a conference, and each person is answering questions. We did want to announce, before we jump right into questions, a couple of logistical items. The first is on your go-to webinar control panel, that long box that generally appears on the right-hand side of your screen. There's a question feature where you can open up that question box, that little dot triangle that's pointed to the right, and ask any questions that you have, or use the chat feature to ask any questions that you may have. And we will stop for questions along the way. And we also did want to share that today's session is being recorded, and we will be sending out the recording link to all of you who have registered and even those who couldn't attend live today. And then finally, I wanted to point out that there are handouts that are attached in the GoToWebinar control panel. So if you go ahead and expand that on your own screen, you can see that there's several attachments, including the California report, task force report, and also the Maryland task force report are attached here. So we encourage you to dig into those reports more deeply on this topic or any others that you may have interest in looking at more closely. So we're going to go ahead and jump right in, and I wanted to kick off today's panel by first inviting Maryland and California to talk a little bit about their commissions generally and why they were formed and who sat on them, and then we'll dig into the education topic more specifically. So I'm going to start with Dan, who you heard earlier had the opportunity to staff and run the commission or task force in Maryland. So Dan, if you could just tell us a little bit about how that commission or task force came to be and who participated on the task force.
Yeah, sure. Thank you, Joy, very much. It's a pleasure to be a part of this this webinar. I'm excited for this and for the future webinars. This is a really important topic, and it's one that the Maryland legislature recognized as such back in 2015. During our 2015 legislative session, there was a bill introduced at the request of my organization and some other organizations, creating the Maryland Task Force to study maternal mental health. Everybody knows the stats behind it. 1 in 7 women will be affected by postpartum or perinatal depression every year. Over 400,000 infants across the country are born every year to mothers who are depressed. And so, recognizing those issues, the Maryland General Assembly, wanted to bring this task force together to get the unmet need and make some recommendations for how to address it in the state. And we had there was 20-some members on our task force that met all throughout 2016, multiple times throughout 2016 to address different factors. Education was one of them, the item that we'll be talking about today. But we had legislators on the task force, a number of state representatives, including people from our Maternal and Child Health Bureau, our Behavioral Health Administration, our Medicaid Administration, Division of Corrections. We had a number of association representatives from the Hospital Association, our State Medical Society, our Pediatric Society. We had mental health advocates on the task force. Dr. Payne, who's a panelist from the Johns Hopkins Women's Mood Disorder Center, was on the task force. And we had, kind of leading to what we're talking about today, we had both a reproductive psychiatrist and a reproductive therapist on the task force, including, and we also had survivors, OBGYNs, social workers. So really kind of covered the gamut of everybody that we thought, would have something to input on the topic, and came up with some really good recommendations at the end. A total of 15 recommendations that you can look through in the report that you have in the handouts. So I'll stop there and let me know if there's anything else you want me to say about that, Joy.
That's great. No, I think that's helpful, Dan. I'll quickly give an overview of the California task force that was formed. And again, both of these task forces ran independently, were formed kind of independently through legislative initiatives in those states, and we're expecting that other states, and perhaps with some of your leadership on the phone, to start to do something similar going forward. But here in California, we have the opportunity to staff the commission or task force here in California that ran for about 18 months and really included multiple stakeholders, just like Dan mentioned, from various medical societies or trade associations, hospitals, hospital trade association, the insurer trade association, the Medicaid department, various advocacy groups, mental health representation, A1, the nursing organization that's focused on the perinatal period, etc. So very much a similar makeup, and also, again, both entities issued reports to the public and the legislature, and that's what we're going to do a deep dive on around education specifically today. So thank you so much, and feel free if you've got questions on the reports to ask those. We'll have time at the end of the session to answer those general questions about commissions, or you can also email myself or Dan directly on commissions specifically. So Dan, that's helpful. I appreciate that overview. And we wanted to start off by digging into education just to make sure we're all on the same page and have a chance to level set around psychiatry specifically. And really, what are the trends in psychiatry, both from a general psychiatrist perspective on this topic and a reproductive psychiatrist perspective on this topic? And we're going to hear from the the two psychiatrists first, and then also Margaret Howard, who is chairing a committee that's specifically interested in addressing psychiatrist education. So I want to start first with Jennifer. I think I'm going to start with you and ask you just to help us understand what is the role of a general psychiatrist, and then what is a reproductive psychiatrist?
Sure. Thanks, Joy, for having me on. So I consider myself a reproductive psychiatrist because I have built my career and practice around managing women, particularly during and after pregnancy. And a reproductive psychiatrist in general is an expert in that area. So I would say that we are familiar with what medications we can and cannot use during pregnancy. We keep up with the literature, et cetera. I do a lot of consults for women who have mood disorders who are contemplating pregnancy, and I give them and their psychiatrist recommendations about how to manage their mood disorder during pregnancy. I think the role of the general psychiatrist here is absolutely critical to managing women during and after pregnancy, because there aren't enough reproductive psychiatrists to go around. But it's a complex area, and those of us who specialize in it really depend on general psychiatry and OB-GYNs and other physicians to help us manage the number of women there are that go through pregnancy who develop depression or bipolar disorder.
That's extremely helpful, and I think bipolar disorder, that word too, that we ought to spend a little time on that. I think I'm going to save that topic for just a moment. But Jennifer, very, very helpful. Let me ask you this, and I think one of the points of confusion, and is this a legitimate subspecialty and provider type, centers around the fact that there really is no testing organization for reproductive psychiatrists at this point. Do you have thoughts on that, and can you comment on that? I think we'll then move into asking Dr. Howard to also comment on that testing piece, and also some fellowship training after we hear from you, Dr. Payne, on sort of the legitimacy and the claim that really this isn't a legitimate provider type or subspecialty. Any thoughts on that?
Yeah, so officially that's true. It's not a subtype or a specialty that has testing or an official license that you have to go through certain training in order to be considered a reproductive psychiatrist. I actually think that will probably change. I know that there are a number of organizations that are working on developing specific criteria and education in order for people to really prepare themselves to be a specialist in this area. I do think it is a specialty because the literature on this is complicated and big. And I've spent my entire career focusing on this area, and I still run across literature that I haven't seen before. So it's not an official specialty yet, but I think it's something that will likely come down the pipe.
That's helpful, Jennifer, and we'll talk a little bit about that testing recommendation that comes out of the California report and development of a testing process in just a moment. I want to now turn it to Dr. Howard. A little bit first about who is the Perinatal Mental Health Society. We'd love to hear you talk about that, Dr. Howard, first, and then talk a little bit about the work that the Education Committee is doing. And then Stuart, Dr. Lustig, we're going to turn it over to you next because I imagine you have lots of thoughts and also know a little bit about the American Board of Psychiatry and Neurology and the process around development of a super specialty in this area. So we'll come to you in just a moment, and first turn it over to Dr. Howard. Hi, Dr. Howard.
Hi, Joy. Thanks, and thanks so much for having me. The Perinatal Mental Health Society was founded about 2 years ago in 2015. There was a group of about 8. We're now up to about 10 founding members. It's a multidisciplinary team represented by OBGYN, psychiatry, psychology, nursing, and with this, our mission is, the study and treatment and advocacy of perinatal mental health. Starting in 2018, we will become known as the Marce of North America. So there were all kinds of administrative and political and financial reasons why we didn't start off with that title. But that's going to change over in 2018. And as part of our training and advocacy, we're putting a lot of emphasis on education and training, primarily of medical doctors, most notably psychiatrists, but also included our OBGYNs, family medicine, and other specialties. We are partnering with the National Task Force on Women's Reproductive Mental Health. And this is a group that was founded in 2013 to investigate the current state of residency education about reproductive psychiatry. And it has, kind of blossomed into also looking at fellowship programs. So right now, we are in the process of developing what I think to be a very robust curriculum that is going to be web-based and can be used for training physicians at multiple levels. So this is residents. It's going to be designed to at different levels in different fields, also fellows and practicing physicians. Now, this website, which isn't up and running yet, but I suspect it will be early next year, will be freely available. Some of the materials are designed for self-study, while others have a facilitator and trainee portion so that residency programs who don't have an expert in perinatal psychiatry can still offer an in-person classroom experience. There's over 30 perinatal psychiatrists from across the country who have been involved in creating this. And while it isn't fee-based, there will be a CME portion for each module. And the content is free, but those who want CME credit and also a certificate upon completing all 14 modules, there will be a fee for that. So I think this is really exciting. We put our initial efforts into residency training because, as is widely known, there's such a dearth of training among general psychiatry residency programs, and yet we know from the epidemiological data that there are women across the country, across the world really, who are suffering from perinatal mental health disorders and need specialized care. Since 1998, and in particular since 2016, there has been really an explosion of women's mental health fellowship programs. There were 5 alone that opened in 2016, and these women's mental health fellowships are not ACME ACGME accredited, so they're not officially recognized by the Graduate Medical Education Accrediting Body, but I think we are moving in that direction. And if it's a formally accredited fellowship, that means that there are going to be core competencies that are required, and we're in the process of developing those core competencies anyway. So, you know, there's a lot of movement in the field, and we're really very excited about it, and, you know, excited to be, you know, just part of this movement.
That's great. And I think, Dr. Howard, what we're hearing you say is that the Education Committee of the Perinatal Mental Health Society is really focused on build-up of fellowship and residency training programs and working with accrediting bodies, et cetera, to establish these programs. Am I understanding that correctly?
Yes, yes.
Great.
Because one of we're aiming to get more standardization across the country.
That's really helpful. I think we're going to have some questions that kind of pour in on this topic, but extremely helpful to get that background. And folks on the line, feel free to start sending in your questions, actually through the chat feature. I'm reminded, not the question feature, so feel free to use that chat feature if you have questions that you want to ask at this point. But Dr. Lustig, I have a feeling that both as a practitioner or an expert sort of in general psychiatry and the role of general psychiatrists, and also as a super specialist yourself, as a child and adolescent psychiatrist, that you might have some thoughts on all of this, and we would love to turn it to you and get your thoughts on the role of the general psychiatrist and also education generally. And Dr. Lustig, you might be on mute.
Can you hear me now, Joy?
We can hear you. Yep, great. Thank you.
Okay. Thank you. It's a pleasure to be here with all of you. And you're right. I do have a somewhat different perspective on the issue of training and specialization for reproductive psychiatry. And that is this. Well, I think there's no question that there will always be clinicians who are more expert than others in any particular area, and that's certainly true in this area. I don't see that there's anything within the field that could not be or should not be able to be achieved by a general psychiatrist. And if we look at the kinds of topics that have come up as we've been talking so far today, for example, we've heard about the pharmacology that's involved, the medication treatment. There are certainly lifestyle or major life cycle events, rather, that occur around the reproductive period, and there are traumatic events that could happen, whether it's a miscarriage or whether it's a stillbirth or a pregnancy that did not result in the outcome that a family was hoping for. But these are not the kinds of things that a well-trained general psychiatrist would be unable to address. And so to separate that off and say, oh gosh, we really need a specialized group of folks to deliver the optimal care, I think creates an unnatural dichotomy between reproductive folks who have special expertise in that area versus everyone else who I think should have competence in that area. And the ACGME, the Accreditation Council for Graduate Medical Education, specifies 6 core competencies that are that span across all specialties in all areas of medicine, and one of which is systems-based practice. Practice-based learning improvement is another, the latter being the drive to acquire more knowledge to improve one's clinical abilities as you go throughout the professional life cycle. And no reason I can think of why a competent general psychiatrist couldn't continue to treat women and treat them around the particular life cycle events that we're talking about today.
Well, and thank you, Dr. Lustig, for raising that point. And I imagine that much of our audience right now is feeling like, oh my gosh, is that really the case? And a belief, and this is why we wanted Dr. Lustig to join us, because we know that he represents the voice of many psychiatrists in the field, and so we wanted to tease out. We know this is controversial, but tease out then what really should the role be of a general psychiatrist versus, what many in the field believe, is a need for this super specialty in reproductive psychiatry. So I just want to acknowledge that, and that's part by design, that we wanted to hear that voice. Those folks that do a lot of speaking in this field have heard this before and know that this is a belief, and so we wanted to take some time to kind of work through this with all of you on the line as well today. And so what I want to do now, and I imagine that Dr. Payne, you've got some thoughts on this too, but I would like to call attention to the core competencies that are in the California White Paper. And what I'd like to do is read through them briefly. The difference between what California determined would be a core competency for a reproductive psychiatrist versus a general psychiatrist. And this is one of the core work products that was developed out of the California group. And then before we go back to the psychiatrist, I actually want to turn it over to Dr. Flanagan, an OBGYN, who sat on that California work group, task force rather. This was really the most, I think it's safe to say, contentious part of the work that we did in California, was to talk about training and different levels of expertise and what's needed and what's not. And so I'll turn it over to Tracy next to talk a little bit about that process generally and share any thoughts you have, Tracy. And then we'll circle back through the reproductive psychiatrist and Dr. Howard to address Stuart's point. So let me go ahead and read this. And for those of you who have downloaded from the handouts page of the GoToWebinar control panel, you'll be able to follow along as well. The core competencies are on page 17 and page 18 of the California report. The specific core competencies that we're looking at now for general psychiatrists and that reproductive psychiatrists are on page 18 of the report. So let me just read through these. It's going to take a minute, but I think you all will appreciate this to wrap your head around what this report says. First is that general psychiatrists would understand signs and symptoms and the range of maternal mental health disorders, including postpartum psychosis, which places, and the risk factors, which place women at higher risk for, and factors which place women at higher risk for a maternal mental health disorder. So again, signs and symptoms, including the signs and symptoms of postpartum psychosis, general psychiatrists again, and the factors that place women at higher risk for maternal mental health disorders. Next, general psychiatrists should know about valid screening tools for depression, anxiety, and bipolar disorder, where to find them, and how to, the valid screening tools during this perinatal period, and how to select and use a tool, including when to screen for bipolar disorder. So Stuart and Dr. Payne, I think your wheels are turning. I'm going to keep going. Number 3, demonstrate competence in assessing for safety, particularly suicide and infanticide, and instituting appropriate acute treatment when needed in this pregnant and postpartum population. Number 4, understand how different diagnoses differs for pregnant and postpartum women versus the general population. So distinguishing between a particular disease or condition that present with similar symptoms and what it might look like in the perinatal population versus non-perinatal population. Develop knowledge of the menu of prevention and treatment options, including non-drug treatments, drug and non-drug treatments, and non-clinical alternative practices. Again, right now we're talking about what general psychiatrists should know. The next one is recognize the importance of social support and alternative psychotherapy, and how to develop a plan for assisting patients in accessing these resources. The next one, demonstrate competency in counseling women on the risks of untreated relapse versus the risks of potential medication use in pregnancy and lactation. Again, this is a general psychiatrist core competency. The next is ability to appropriately counsel women with psychiatric illness who are planning pregnancies and will need treatment, whether whether they're drug treatments or non-drug treatments. And a couple more, demonstrate the ability to appropriately counsel women of childbearing age on methods of birth control, their effects on psychotropic medication and or symptoms, and where to go for family planning. The next one, develop knowledge of when to seek specialized consultation from a reproductive psychiatrist. So we know that's a sticking point. And then two more under general psychiatrist core competencies. The next is recognize and refer to local network of maternal mental health services that are available in that provider's community. And then finally, understand the trouble around breastfeeding. And this was actually something that was debated a little bit in the California group, but understand that trouble with breastfeeding can be a risk factor for anxiety and depression. And some agents used to help increase breast milk supply may trigger anxiety. And this shows up in all of the core competency sets for all provider types. Just understand the nuances of breastfeeding. That's what's listed under the general psychiatrist core competencies. There's just three more that are added in this document to reproductive core competency, reproductive psychiatrist core competencies. Let me read them quickly, and then I want to turn it over to Tracy, not to talk about OBGYN specifically, Tracy, and I'm hoping I'm not going to put you on the spot, but just sort of this general sense of core competencies, and then we'll turn it back to Dr. Payne and Dr. Lustig and Dr. Howard, and then we're going to move on to the role of OBGYNs in this space and education. So let me go ahead again and review the core competencies for reproductive psychiatrists. The first is, in addition to all of those things we've already mentioned for general psychiatrists, we want reproductive psychiatrists or those with a super specialty or super focused, specialty area, to demonstrate ability to manage complex medication regimens in pregnancy. That's the first. Number one, demonstrate ability to manage complex medication regimens, which MDs often call cocktails, right, in pregnancy. Provide pre-pregnancy and postpartum consultation to MDs. Dr. Payne, you've talked about this, including general psychiatrists, for women with severe mental illness and those that are on complex medication regimens. So those that are taking cocktails and that, this very specific recipe that works for this woman of drug treatment. And then the last one, the third one, is to serve as a resource through expert consultation with a team of providers, including perinatal care, pediatric, social services, and others as needed in the community. So I thought that would be helpful to just go through those briefly. And again, those of you who are on the line and haven't been able to download that California report, it's all there as an attachment or a handout in your GoToWebinar control panel. You can download that full report and take a look at what I just read. With that, Tracy, again, I hope I'm not putting you on the spot. Let me know if I am. Just want to get your sense on the need for core competencies generally and anything that you want to talk about on this point before we turn it back to Dr. Payne and Dr. Lustig and Dr. Howard.
Thanks, Joy. I'm going to speak both as a practicing OBGYN as well as an overseer of a large system of care that kind of addressed this in the last 10 years more head on. And I think many people on this call know that when women become pregnant, their OBGYN is sort of their home base. And to that end, the question is, what do OBGYNs do as far as identifying and screening for this? I think you heard in the beginning of this conference that this is a huge problem. It is equal opportunity. It affects women throughout their pregnancy as well as postpartum. There's no way that the mental health system could absorb all of this burden of symptoms. And so I think it has to be a shared responsibility between both primary care, OBGYN, as well as our mental health colleagues. And I think the nuance here is the most sick, which really is a small percent, really needs to be co-managed or even managed by psychiatrists or reproductive psychiatrists. But a lot of the lower level degrees necessarily have to be at least identified, assessed, and even in some ways managed by OBGYNs. I can tell you in my own practice, 4 out of the 5 women that I identify with depression symptoms will not go to see a mental health provider. There's too much stigma associated with it. There's too much cost. So I realized that I had to develop a competency as well as my other colleagues. And I would also say that one of the things that really needs to be done is we need to destigmatize and normalize asking about this. And once we do that, it becomes part of routine care. And there's a lot we can do as primary care OB/GYN providers. Getting back to, Joy, your question about core competencies, what we've been able to do within our system is to expect the following core competencies: that we would, as OB/GYNs, understand the signs and symptoms of some of these mood disorders, that we would know and use a screening tool. We happen to use the PHQ-9 that's changed a little bit. We have actually asked our colleagues to screen 3 times during pregnancy and postpartum. So that's a competency. We want them to know what to do when somebody scores high. We want them to be able to ask about safety, you know, about suicidality, about whether somebody's going to harm themselves or somebody else. We also want our OB/GYNs, and some feel more comfortable than others on this, about medications that they could start either in consultation with their primary care internal medicine folks or with psychiatry colleagues. And there's variable comfort with that, but also about the safety of whatever medications are used. And also know about networks of services. We know that perinatal depression responds to lots of different kinds of interventions between support, exercise, counseling, telephonic support, I mean, medication. There's lots of different interventions. And then, of course, adding the piece of breastfeeding. So I would say that, you know, that is kind of core to OB/GYN. I think the one piece that people feel most variable and uncomfortable about is initiating medication. And I'll stop there.
Okay, very helpful. I'm guessing that our listeners and the 84 people that are with us live right now really appreciated that, Tracy. I always do. And the critical role that OB/GYNs need to play. I know I'm just going to anticipate what the feedback might be from those that are on the line. Just want to acknowledge, and again, we're going to address this in another webinar, that pediatricians can also play this role. We love what Kaiser Northern Cal is doing, and again, the Kaiser model is a little different than the rest of the country, but Tracy has really led the way and published some research on this topic, 2 pieces of research on this topic and these points that she's talked about now, that if we start to screen during pregnancy, that we really normalize this work, and that maybe the role of psychiatrists and perhaps super psychiatrists, right, super specialty, those that are reproductive psychiatrists, whether there's a formal designation or not, really can play that role of sort of consulting with OB/GYNs like those in Tracy's practice up in Northern California around medication safety and use. With that, I'm going to stop and say, Jennifer, I think we want to hear from you next, and then Dr. Howard, and we'll turn it back to you, Dr. Lustig. So, Dr. Payne, anything that you can add?
Yeah, so first of all, I completely agree with Tracy that the role of the OB/GYN and, you know, as you mentioned, Joy, the pediatrician, the primary care doctor, et cetera, is critical. And I said that at the beginning of this webinar. I actually really like how you've done this. You've outlined these core competencies in California, and I think they make complete sense. And I will say what I worry about as a reproductive psychiatrist is that while I think it would be ideal to have every psychiatrist be competent in managing an uncomplicated case during pregnancy, there isn't a week that goes by that I don't see cases that I would consider simple to manage during pregnancy, but their doctor does not. And so I think I've said once, I would love to be put out of business, because I think it's really critical that not only general psychiatrists, but OBs and primary care doctors and pediatricians be educated in this area, and really know what they can prescribe, what they can't prescribe, etc. But I think education is just not at that level yet. And when it is, I think we can talk about whether we need a specialty for reproductive psychiatry. But right now, there's not a level of education for those front-end providers that allows them to knowledgeably manage women during pregnancy much of the time.
Okay, Dr. Payne, thank you so much for that point. And I think, we in this field often hear that general psychiatrists will often refer women back to their OBGYNs because they're pregnant to treat these disorders. And then I think what you're hearing is that you often hear from general psychiatrists that, they just don't feel competent. And I think, Dr. Lustig, you said, I think we're probably all on the same page, and we'll come to you in a moment, Dr. Lustig, but that competent psychiatrists, general psychiatrists, should be able to treat this. And Dr. Payne, your point, I think, is that we just don't have enough of that yet. People don't feel competent. General psychiatrists don't feel competent. And then I also, before we turn it back to Dr. Howard, I would love for folks to just keep in mind the general shortage of psychiatrists and reproductive psychiatrists. We're not going to talk about the need for telepsychiatry on this call, but again, just to recognize that a lot of women are struggling and don't have access to any of these psychiatrists right now. I just want to make that point, and again, we'll dig deeper into that topic later. The need for systems change and access control, if you will, or interventions, if you will, down the road. But Dr. Payne, thank you. Do you have anything that you want to add before we turn it over to Dr. Howard?
No, I think what you said was well said. And I think until we have a system in place where residents as a whole are trained in this area, that we're going to need some specialists in this area. And I'll stop there.
Okay, great. Let me go ahead and turn it over to you, Dr. Howard, to talk about your response to what you've heard so far.
Great, thanks. Just kind of piggybacking on what was said, in listening to Dr. Lustig, I think that absolutely the ideal would be that all general psychiatrists would not only feel competent but also be competent in the pharmacological treatment of pregnant and breastfeeding moms. The reality is, though, at least from our experience here doing this work since about 1997, is that general psychiatrists do not feel comfortable medicating pregnant and breastfeeding women. And so we often, because we exist, we have such a large and well-known specialty practice, they refer to us. But, we're just one very small fraction, of the country. And so part of our initiative to develop these web-based training modules is for not only it to be integrated into all psychiatry residency programs, but also be accessible to general psychiatrists who may not feel comfortable or competent, but to then get this web-based training so that they would. And then so many more women will be reached. So that is, that's sort of the reality as I've seen it over the years. And the second point that I'd like to make is that I agree wholeheartedly with Dr. Flanagan's, all of her statements about because of how commonplace perinatal mood disorders, anxiety, and depression are, that all OBGYNs need to, at the very least, be screening for it and be able to recognize it. And I think that in our experience, our patients they do develop this bond with their OB, and they are much more likely to reveal to their OB that they're having depression or anxiety. And as she said, there is a great reluctance because of the stigma associated with mental health treatment. There is a great reluctance of women to seek more specialized, mental health treatment. And the other point that I'd like to make is that in terms of the postpartum period, the captive audience in terms of provider group are pediatricians or pediatric providers. But what we are running into is from the woman's standpoint, the patient's standpoint, is she's very reluctant to disclose to her pediatrician, even if the pediatrician screens, that she's having depression or anxiety, because there's an even heightened sense of shame or guilt or fear that somehow their baby will be taken away from them. That's why we have a whole group of pediatric practices in the state of Rhode Island. I met with them yesterday, as a matter of fact, and they've taken on as their cause to institute, statewide screening in pediatric offices of their patients' mothers, for postpartum depression, and they're very much into it. And I think with a slow, but gradual mindset, there could, hopefully be some sort of a cultural shift in the willingness on both the part of OBs, although I think OBs are way farther ahead, but also pediatricians to screen, for these disorders. Because as I tell them, they say, well, the baby is, the children the children are our patients, the baby is our patient, and it's like, but your patient's health and well-being really does depend on, caregivers' health and well-being. So it behooves you. And that, they always agree with that. So I'm hopeful that with more of these kind of public forums that we will begin to shift our thinking, our acceptance, that this is indeed not only a common problem for many women, but also very, very treatable.
That's great. Dr. Howard, thank you so much. I'm sure Dr. Flanagan appreciates that feedback. We have some great questions coming in, but before we get to those, I do want to turn it over to Dr. Lustig. Dr. Lustig, thoughts on all of this?
Sure. Well, I certainly wouldn't disagree that there are psychiatrists out there who may have less comfort than others in working with pregnant women or around reproductive issues. That said, I still don't believe that the solution is a specialty in this area. I think, and I would agree with the earlier point, that the goal really should be, and the focus of energy should be really on enhancing the training of general psychiatrists so that they do feel more comfortable. In much the same way that any psychiatrist ought to be able to treat depression, any psychiatrist ought to be able to treat schizophrenia. We don't have specialties for those, although we certainly have people who are more expert than others. But these are and remain for half our population really garden variety issues. And so that's where I think there's a hope for making a dent in this problem. And the good news for training programs is, although the curricula are already quite full, there are multiple ways of helping trainees become familiar with life cycle issues such as pregnancy and such as breastfeeding. And those are seeing more patients of this kind, or participating in consultation groups, or reading and research programs. So any number of ways of doing this, and I think that would be a good use of people's expertise and their resources.
Okay, great. Thank you, Dr. Lustig, for sharing that point. And again, I think probably majority of our listeners are those that really might feel differently than Dr. Lustig. So I do want to stop for just a moment. Dr. Lustig, what we've been asked to share is, what we're calling at 2020 Mom and the National Coalition, this sort of craveable content. People are asking us to share, tell us what you are hearing and let us hear it firsthand. And so we're so excited to get to bring this webinar to our larger audience and let them get to hear from you directly. And I think what makes your comments particularly interesting is is coming from someone who has a broad perspective over the field of psychiatry, Dr. Lustig, but also you do serve as a super specialty, if you will, in child psychiatry. And so I would love for you to take just a couple minutes, if you would, or moments, if you would, to talk about, what do you think the nuances are between child psychiatry and what the field has coined reproductive psychiatry, if you don't mind.
Sure. Well, very briefly, there are significant differences between the field of child psychiatry and the rest of psychiatry. So there are entire disorders that occur only in in children, or primarily in children, or start in children, at least, that would be recognized differently from their successive iterations in adulthood. Certainly the medication issues are different in children as well. There are other treatment considerations, family systems issues that aren't irrelevant for adult psychiatrists, but certainly aren't paramount in the way that they are for child psychiatry. And even the basics of just how do you interview a child with different techniques, whether it's play therapy or the use of games or the different kind of use of collaterals, very different. And I think that really does take some fairly specialized training, but I still haven't heard anything so far in the field of reproductive psychiatry that couldn't and shouldn't be accessible to a general psychiatrist. And again, I'll certainly concede that there are many areas where my colleagues on this call would have far more expertise than I would, or some of my adult psychiatry colleagues would. And for that, we would certainly seek them out. But at the same time, we ought to be able to handle garden variety, fairly basic or uncomplicated cases that come our way. And so I see that more as a training issue, again, as opposed to a specialty issue.
Okay, I'm going to recap because this is really a critical point. And again, thank you for being with us, Dr. Lustig, and to share your opinion. What I think I hear you say is that a subspecialty might require additional nuanced expertise levels. The difference between a child psychiatry specialty, for example, is that there are different disorders that don't come up in adulthood, perhaps that come up in childhood, and perhaps that nuance doesn't exist in the reproductive period. Any comments on that? And then I do feel like this is something that is helpful for us to discuss as a group. We have a little bit more time, and for all of our attendees to get to listen to. Anything you want to add on that point? And then I think I also am hearing you say at the same time, though, Dr. Lustig, that garden variety, you sort of acknowledge that maybe general psychiatrists don't necessarily all feel competent at this point to even handle garden variety, but perhaps there are some situations that would require additional levels of expertise. You're not sure that would require additional credentials, but there is perhaps a need to consult with people that have extra expertise for non-garden variety types of reproductive mental health disorders. So, am I getting that right? And anything you want
yes.
to
I think you nailed it, Joy. That's exactly right.
Joy, this is Tracy. Can I make a comment?
Yes.
I think we're all saying that there needs to be education at every level. This is a huge issue. It involves lots of women. It is not, a boutique, tiny little area that only one person can take care of. We all own some of this. And it's all about severity and, complexity of these cases that would, generate where we might want to find our expertise. And I think we all agree that education is needed at every level, whether we're talking about primary care or general psychiatry or reproductive psychiatry.
Thank you, Tracy. I think you're spot on. Everyone is on the same page with respect to the need for additional education, which this webinar is about. Before we go back, actually, I do want to go back to Dr. Payne. Anything you want to add, Dr. Payne, to kind of add on to what Tracy and Dr. Lustig has said? And then Dr. Howard, will back to you.
I completely agree with everything that's been said. And including that I think general psychiatrists should be competent in this area. And I think there's a really strong movement to make sure that everybody and their brother is educated in this area, from the psychiatrist to the OB-GYN, and the patients as well. And so I think we do not disagree about the need for education. As to whether reproductive psychiatry should be a specialty or not, you know, I think I would argue for it, principally because there has not been broad education to date. And so there need to be psychiatrists who are specialists in this area, who manage a lot of women. I think that there are a lot of issues that come up specifically during pregnancy and postpartum that are very different from issues that come up for men. So I do think that this is a special area, and I think eventually it will likely be something that is licensed, or you have to test or do a specific fellowship. But I think we all agree that everybody needs to be educated in this area. And I'll stop there.
This is Dan. Can I add something?
Yes, please, Dr. Lustig. Or is that you, Dan?
Yeah, this is Dan. So,
okay,
you know, I've been listening to this back and forth, and, you know, from a layperson, you know, I'm not a doctor, from a layperson's perspective, and from the perspective of, you know, staffing the Maryland Maternal Mental Health Task Force, you know, we go back and forth here about whether we need a specialty reproductive psychiatrist or a broader, you know, understanding of these issues across, you know, across providers. And I don't know why that these things are mutually exclusive. You know, I think that there's a need both for specialty reproductive psychiatrists and a broader understanding across you know, different provider types. You know, during the task force process in Maryland, we relied on multiple resources, you know, in our discussions around you know, education needs and things like that. But one of the things that we relied on in particular was a series of focus groups commissioned by the Healthy New Moms campaign. And just full disclosure, the Healthy New Moms campaign is a public education and advocacy campaign program of the Mental Health Association of Maryland. HealthyNewMoms.org has a lot of resources for anybody that wants to go there. But what the focus groups found, and they were focus groups of consumers and providers. What they found among pregnant and new moms is that pregnant and new moms found a lack of maternal mental health specific information and input received regardless of which provider they went to, whether it was an OBGYN, whether it was a psychiatrist, whether it was a pediatrician, and then, you know, just they're finding little support from any of those provider types, which calls out for, you know, broader understanding across specialties. And there was a similar frustration amongst providers. Again, psychiatrists, OBGYNs, there was a focus group of providers that, and none of them felt comfortable, you know, felt completely comfortable, you know, in dealing with the very specific needs. You know, psychiatrists didn't feel comfortable dealing with the specific needs of their pregnant and postpartum patients, and OBGYNs didn't feel comfortable dealing with the psychiatric and mental health needs of their patients. So, I mean, I really don't think that they're mutually exclusive. I think there will be a need for a specialty reproductive psychiatrist, but at the same time, a broader need across the spectrum, and that's what the Maryland Maternal Mental Health Task Force recommendation for education was around, trying to get to that broader training.
Well said, Dan.
No, I appreciate that, Dan. I think let me turn it back over to Dr. Lustig. Any comments that you have, Dr. Lustig? And then, Dan, I'd love for you to talk about what Maryland is suggesting in terms of education, and then we'll also circle back on, you know, moving education upstream, which I think all of us are interested in doing. And Dr. Lustig, thoughts from you on all of this, and then also kind of moving education upstream and helping more general psychiatrists become competent in this area and feel comfortable treating these women. Let me also add one last point, is that, and Tracy, you might have closing remarks on this point later, because I think you have some thoughts on this, is what we've found and what the research suggests is that OBGYNs and pediatricians, nobody feels comfortable screening in detecting women with maternal mental health disorders, right? No one wants to screen, period, if they don't know what to do with the most complicated cases. And so if you can all frame, that's our goal, right? We want to help identify and treat all women, not just those with super complex needs, which is really what we're ending up focusing on in this session. But Dr. Lustig, I'm going to turn it over to you, and anything that you want to add, and then I think we'll take some time to circle back through all of our presenters. And Dan, we do want to hear about what the Maryland recommendations were on CMEs and CEUs for providers as well. So Dr. Lustig, I'm going to turn it over to you.
Sure, just briefly, I think at the end of the day, we all want to be sure that women get the care they need. None of us would argue with that, of course. But there is also an access issue here. And certainly this is true in my field, in child psychiatry as well. And the way we deal with the shortage in child psychiatry is we make ourselves available as consultants, certainly. But we also try to think creatively about how to extend what we do through other folks who may be competent enough with just a little bit of extra training, for example, whether it's a PA or a nurse practitioner or a pediatrician. And by the way, pediatricians certainly feel uncomfortable screening kids for mental disorders as well. So I think there's that discomfort generally in primary care. But to parse off a group and say, okay, you guys are the specialists, I think is a potential limitation in already limited resources. And so the more we can do to skill up the folks in general psychiatry, I think that's a better use of the limited resources that we have. And I don't think we're that far away, really, quite honestly. Any psychiatrist ought to be able to look up the pregnancy category of a medication. Any psychiatrist ought to be able to understand the grief involved in a miscarriage or a stillbirth. And most psychiatrists can be comfortable with complex medication regimens and can understand the hormonal environment of the female brain, to quote a book on the topic. So I think that would be the way I'd rather see us go, and of course would have a great deal of respect for the folks who do have expertise in this area. And reproductive psychiatrists, as they are called, whether they are a specialty or a certified group or not, I think will always have value to add to our practice. But that's how I would see those resources being used most effectively.
That's helpful. Thank you so much, Dr. Lustig. Dr. Flanagan, anything you want to add?
Yeah, I think that you called out that that we're in a different system, Kaiser Permanente. Yes, we're different, but the fears are still the same. It's really not that different. And I think we all wonder, why is it so hard to screen? Well, it's exactly what Joy just said. Screening is hard because as a physician, you want to make sure that you know what to do once you screen, and that you have people that you can go to or things that you can do. And I think it's pretty scary to screen when you feel like you don't know what to do and you don't really even know what it means. So I think education is key. I can tell you that, our 10-year project involved actually having, cheat sheets and little tools that allowed people to feel comfortable with what does it mean when the PHQ-9 is 12? What does it mean when it's 18? What are the things that you can do as a primary care physician? And I would argue that not only are reproductive psychiatrists a very, very rare commodity, psychiatrists are a rare commodity in most of the country. And so, we as OB/GYNs have to educate ourselves to be able to manage and recommend certain things to our patients. And I will say that the educational things that people can use are certainly through the American Board of OB/GYN, ACOG, our district education sessions, But I think the most powerful educators are our own colleagues who end up doing it. You know, your neighbor who actually did it for the first time and had a story is probably the most powerful educator. So local CMEs and grand rounds where you can turn to your neighbor and say, did you do this? How was it? Was it hard? Those kinds of things are huge educators for people.
That's great. Thank you so much, Tracy. I'm going to just open it up. Any other panelists want to address questions, comments that came up today? And then there's a couple of questions I'm going to bring up through the chat. And we'll also address, there's a lot of great questions coming up, and then I think we're going to address through another webinar on these topics, and I'll summarize what I'm hearing from that chat. But again, circling back through the panelists. Anyone want to make any closing remarks? All right,
this
great.
Is Tracy. I'll make one comment. My advice is don't be afraid of this. It's simple.
I love that, Tracy, and I think all of us do. That's great. We do have quite a few therapists on the line, which we anticipated would be the case. So that's mostly who's in our network so far, and let's acknowledge why. And that's because therapists are often the folks that are hearing from these mothers who haven't actually found treatment and options elsewhere, and often are missed by and not diagnosed by their MDs. So I just want to acknowledge that. But we are hearing from folks. Let me just close this out by saying that there are a couple other webinar topics that we want to address, and you let us know through the chat if you think we're nailing this. We do want to acknowledge that there is a need to address telemedicine, and just generally to acknowledge the fact there's a shortage of psychiatrists and even these sort of super psychiatrists or reproductive psychiatrists that may be able to help general psychiatrists in the meantime, right? I think the bottom line, what we're hearing today, is we want to see some training and some core competencies developed and pushed out for general psychiatrists. But regardless of that fact, there's a shortage of psychiatrists generally. And so let's talk about telemedicine and what that means. So that's one takeaway from me. I'm also seeing in the chat that there is a real big interest in breastfeeding, and what does that mean? And I think there's a few topics we can spike out on that front, including what's the role of the lactation consultant, drugs that may help promote increase in breast milk, and what does that do for mental health? There's some studies that show that some of the widely recommended drugs by lactation consultants actually lead to anxiety. We want to address that. And then also sort of the general role of pediatricians and OBGYNs in lactation, like recognizing this complex area of mental health. So we have telemedicine, breastfeeding. I think we also have just this general third prong around pediatricians and the role that pediatricians play, and also their knowledge around screening, diagnosis, treatment, and breastfeeding. So use that chat feature, or panelists, if anyone has any closing comments. And then Dan, I do want to circle back to you after I summarize those 3 areas of opportunity for the next round of webinars, to talk about what Maryland decided to do around CMEs and CEU-based education. Any general comments? Use the chat feature, those of you that are listening, and then panelists that want to address what I just said around the next 3 areas of opportunity for webinars. Panelists, do you want to jump in? Anyone have anything they want to add? I'm looking at the comments now, and then Dan will circle back to you.
This is Jennifer Payne, and Dan may want to talk a bit more about this, but one of the things that we looked at, we have here in Baltimore, we have something called Be Hip, and and basically it's a telephone line where you can reach an expert in child and adolescent mental health. And so one of the things that we talked about and is being looked at is expanding that to include a reproductive psychiatrist, so that any provider, a psychiatrist, a OB-GYN, a pediatrician, can reach out and talk to an expert about a case that they're seeing on the front lines.
Dr. Payne, thank you so much. And I think some of the folks that are on the line may be familiar with the Massachusetts, it's called MCPAP for Moms program. And it actually started, it evolved around the Massachusetts Child Psychiatry Access Program, which addresses the shortage of child psychiatry professionals like you, Dr. Lustig, and how to provide access to pediatricians, and then expanded to address a shortage of experts to address reproductive mental illness. To your point, Dr. Lustig, maybe there's not a need to address reproductive psychiatrists as a super specialist or with a special designation, but perhaps this is the stopgap, if you will, or the bridge between these disorders, recognizing that there is a super shortage of folks that can help in the meantime until all general psychiatrists are actually trained in reproductive mental health. And Dr. Lustig, any thoughts on that before we circle back to Dan, who will talk about his program's CEU and CME-based education opportunities in Maryland. So Dr. Lustig, turning it over back to you.
Yeah, and that's a great program, and I would absolutely agree that any way we can leverage the expertise of reproductive psychiatry and extend that beyond folks who possess it themselves, I think it's a wonderful opportunity and a real service to patients.
Great. I do want to acknowledge there are several comments in the chat feature, including comments from some prominent folks out here in California, and you know who you are, about telepsychiatry and the need to address that. And so, Dr. Lustig, thank you so much. I think folks are probably landing on the same page behind the scenes about the fact that we really have to address this access issue, not just the education and certification and sort of subspecialty issue, and that might be really the common denominator between what we're hearing today and where we need to go around access. Dan Martin, I'd love for you to comment on training opportunities that you have developed in Maryland, and then we'll close it out for last-minute comments from our full panel.
Sure. Thanks, Joy. I'll just tell you guys real quickly what came of the Maryland Task Force recommendations around training. The recommendations were focused on getting that broader understanding across providers. Through those focus groups and other resources, there was just a crying out from providers, across the spectrum for more training and more resources to help address these issues. So there was those calls and the combined with the prevalence of the illness, led the task force to make a recommendation for the development of continuing medical education options to assure a basic minimum level of understanding among a variety of healthcare providers, whether it be pediatricians, internal family medicine providers, obstetricians, psychiatrists, anybody. So, the recommendation from the task force was to require the state to develop free maternal mental health CME, CEU trainings, including online options. I think it's worth noteworthy real quickly that a portion of the task force supported a stronger recommendation in this area, including a requirement that those certain providers get annual CME, CEUs in this area. Ultimately, that wasn't a unanimous position, and the task force decided to just recommend the development of them. And to get to Dr. Payne's point, the task force also recommended expanding our BHIP program, which was modeled after Massachusetts' MCPAP program, to expand it in the same way that Massachusetts did when they expanded it to the MCPAP for Moms program. So we passed legislation this last General Assembly session that did a number of things. And two of the things that it did do, one, it requires the state to develop accredited training programs, accredited CME, CEU programs for providers around this issue to improve early identification of postpartum depression and perinatal mood and anxiety disorders. And it requires the state to come up with a plan for expanding our psychiatric consultation program in the same way Massachusetts did. So those are just kind of some of the first steps that the state is taking here in Maryland to kind of build that infrastructure that'll start kind of hopefully getting that broad understanding across providers about maternal mental health issues. And we are working, my organization is working now with the state to implement those bill provisions. So we're hopeful that that'll have an effect.
That's great. So much. Thanks so much, Dan. I would just like to wrap up to acknowledge that I think what our next topic should be, and this is why these calls and your feedback through the chat are extremely helpful, is telemedicine and access to providers. And it sounds like we have some great models that we can lift up. And Dr. Lustig, we'd love to learn from you what the what your experience has been around child psychiatry access and the telemedicine models that exist in child psychiatry that we should be looking at. We'll look at those. We'll also, we heard from Maryland that their program called BHIP is a good one to model after. We, of course, most of us know, or many of us in this field who've gone deep in this field know that the MCTAP for Moms, the Massachusetts Child Psychiatry Access Program, and then the added layer, Access for Moms, has been extremely helpful. And perhaps it's a stopgap until we can get all general psychiatrists up to speed and competent and feeling good about treating these providers. If any of you disagree with my recap, we want to hear about it from you directly through email. Don't do it through chat at this point, since we have 30 seconds left. I want to hear from you through email, and you can email me directly at joy, J-O-Y, at 2020mom.org, joy@2020mom.org. And with that, I think we're going to close today's call. I do really want to thank all of the panelists. This is what people are asking for. We want to hear from the people that you hear from directly, and we make those conversations available to everyone. I think that's exactly what we did today. We so appreciate all of your expertise and your willingness to join us today. More to come. There's lots brewing within ACOG and within Postpartum Support International around training. And I just, last minute comment is to acknowledge that all this great work is happening. And we're thrilled that everyone's interested in joining us in these conversations. Again, email me with any feedback that you have directly about ideas for the next set of webinars, and or feedback on today's webinar at joy, J-O-Y, @2020mom.org. And with that, I want to thank our presenters and panelists today and welcome all of you. Keep following us, and we will be bringing more content like this to all of you in the near future. Thanks so much, everyone, and we're going to close the call today. Thanks, everybody. Take care.
Thank you.
Thank you. Thanks, panelists.
Thank you.
Thank you.